I'm Selma Schimmel, and we are at the 35th meeting of the European Society for Medical Oncology in Milan, Italy, where we're now joined by Professor Nathan Churney. Hello, how are you?
Hi, Selma. I'm terrific, thanks.
I'm very happy to talk to you about palliative care, a subject I think that needs to sort of come out of the closet and have a little bit more light shed on it. I know it's a scary topic, but it is a part of life, and you're one of the world leaders in this area.
Well, you know, the sad reality is that anywhere between 40 to 50% of patients who have cancers aren't going to be cured of them. You know, that 40 to 50% depends on what sort of cancer you're dealing with and where you are in the world, what access to treatment that you have. But you know, these patients have special needs. They have needs in terms of wanting to get the best of care to try to optimize the duration of survival, but they have also further needs looking at issues related to the quality of their lives and their families' lives.
It seems that the whole area of palliative care has really excelled in Europe, especially in the UK. I don't sense in the United States we're still seeming to raise that to a higher rank.
I think it's very patchy. It's very variable, certainly very variable within Europe. In the United States, actually, a lot has happened really over the last 15 years since the Project Death in America, which was heavily funded by George Soros. The money that he put in really seeded projects all over the country, and now with the development and the recognition of palliative medicine as a medical subspecialty in the United States, the scene is really radically different to what it was 10 to 15 years ago.
How does one engage in the discussion of palliative care with their medical oncologist, and likewise the medical oncologist with the patient?
I think that patients need to clearly articulate to their doctor what their concerns are. And I think that patients often undersell themselves by just talking about, well, how long am I going to live, without asking the questions and asking the really important questions. How well am I going to live? What are the sort of problems I can anticipate with the particular illness that I have? And what can we do to help me to live not only as long as possible, but as well as possible? Very recently, there was a very major and important study which came out of Mass General Hospital, where they took patients who had advanced and incurable lung cancer, and they were randomized between those who received proactive palliative care from the day of diagnosis to those who received it just on an as-needed basis. And the patients who received proactive palliative care not only lived better, they lived longer, and they lived longer despite receiving less chemotherapy. So this is a really, really important demonstration of the importance of integrated oncology and palliative care from the go-get for patients who have incurable disease.
The scope of palliative care, it's pain management, pain control. What else is involved?
It deals with both the physical aspect, the psychological aspect, spiritual aspect, nutrition, exercise, families. They're really the 6 different dimensions that I would want to address when I'm working with a patient and their family.
How does a patient and a family member know when it's time for palliative care?
It's really almost time from the point of diagnosis. Everyone, even patients that have got curable illnesses, want to live well and want to get through their treatments well. Obviously, when you're dealing with an illness which is potentially life-threatening and which may not be cured, these issues are going to be there. Certainly for patients with diseases which are not curable because they're just too far advanced, these are going to be a major focus. So the context changes depending where you are along this spectrum. And not only the context, but the emphasis, how central a part this needs to be to your care strategy. And certainly patients who've had multiple lines of therapy, where the benefit from future therapies is now getting down to very, very low, and the risk of side effects is getting greater than the risk of than the likelihood of benefit. That's really the point where people need to say, look, hey, treatment is not only about chemotherapy. Treatment is about global care strategy, and maybe right now, chemotherapy and things like that are doing me more harm than good. I really need to be focusing on these other aspects. And often this is a transition point for people, where and how that transition is managed really is very much determined by the skills and training of the oncologists that you're working with, and the team and the team in the context that they're in. There are many oncologists now who are well trained in palliative care and who will continue to manage you through these phases of illness. And there are other oncologists whose training and expertise in this is more limited, and they're going to need the assistance of someone with specific expertise to help to get you through this as well as possible.
What can we tell patients who are afraid that if they are getting palliative care, which would involve pain control, that they will be too, and I've heard patients ask this, I'll be too drugged, I'll be too tired, I'll be not able to participate with any activities or my family, and so they try to push off their palliative care and many times live in pain instead of getting relief.
I think we need to say, to explain to patients that the aim of pain therapy, or particularly drug therapy for the management of pain, is to get you to a situation where your pain is well controlled and your level of function is improved. Someone who is too drowsy or too sleepy or impaired, that's an inadequate outcome. And there are strategies that one can employ to try to reduce those problems. And often it's a question, because there's a range of different drugs that can potentially be helpful. Often one needs to try medication sequentially to find which drug is going to work best for you. So I've certainly had patients who on morphine or oxycodone they were getting good relief, but they were far too drowsy with them. But if we swap them over to a different medication, such as methadone or hydromorphone, we just found a better balance. And this issue of tailoring therapies, being sensitive to side effects, having a partnership between the patient and the clinician with a common stated aim and direction.
One thing that you said to me is so important, and that is that integrative part, the psychological, the psychosocial, the spiritual. It's not all clinical. It's the integration of all these other human components. So we're a patient as a human being and not our disease.
When I talk of my clinical service, I have a team of people that provide palliative care, and so we're working from different angles. So in my team, I have a psychologist, a psychiatrist, a spiritual care team. We have a complementary medicine program, a music program, and we will tailor the input of these various people depending on the needs of their specific patient and their family. And as part of that, we will often do family meetings as well to address wider family issues related to children, issues related to future care planning, to what sort of care can be done in the home. When does the home become a place of when is it a place of refuge, and when is it a place that starts to become a threat because it's just too hard to deliver the care that's needed in the home.
And in your area of specialty, it's really not just the patient. Your other dynamic partner is the family member.
Absolutely, absolutely.
The takeaway message that you want to tell a patient who's facing this issue in their life right now?
I guess the takeaway message is that we are, as healthcare providers, we are vitally interested in the quality of your life, despite the fact that you may be living with an incurable illness, your life and your family's life, and that we need to be able to make the commitment that when death approaches, that we can keep you comfortable and provide adequate supports to your family members and loved ones.
One of the things we talk about a lot is the difference between healing and curing.
Yeah.
And healing also encompasses the death experience. One can be cured of cancer and never really internally, on an emotional or spiritual level, heal. And then one may not survive physically cancer, but they've resolved so many issues in their lives and they're at peace, and to me that's healing.
One of the aspects which has been so beautifully demonstrated has been working on the issue of dignity, and specific strategies have been developed to help promote patients' sense of dignity and to help preserve patients' sense of meaning, even in the context of a very limited life expectancy.
I think you're working in an area of medicine that is very scary to people, and it is so fundamental to what it means to be human.
Absolutely, and as such, it's also, despite the, one of the things I try to teach medical students is that even in the context of incurable illness, you can have phenomenal medical success. And we see this on a daily basis, and there's a lot of reward in that for the clinicians involved.
And we also have to train doctors, and this is a big issue of, you're not a failure if you can't save your patient. Yeah. And many times doctors who still struggle with the issue of mortality, patients feel their doctors bail on them when the going gets rough, and we need to help doctors feel comfortable with end of life. It's not about failure, but you got to be able to go around the whole circle of life.
But if the doctor isn't comfortable doing it, he just needs a team. He needs other people that can help him deal with his patient's needs through this phase of life. And so this is why so many of the quality cancer centers in America have now developed palliative care programs to be able to meet all of their patients' needs.
Thank you, Dr. Nathan Churney from
Shaare Zedek Medical Center in Jerusalem.
In Jerusalem. Thank you, Dr. Nathan Churney from Shaare Zedek Hospital in Jerusalem, Israel.
It's a pleasure.
Thank you again.